one different surgical approaches in order to tailor our management in order to better suit the patient. So, grossly, the approaches are posterior, posterolateral, lateral, or anterolateral. So this one is posterior, posterolateral, lateral, anterolateral. The posterior approaches are the midline suboccipital and infratentorial supracerebellar. The skin incision in both cases is on the midline. This is what I have seen at Cluj last week. The patient had an epidermic cyst of the fourth ventricle, which means the lesion was located on the middle. So the easiest way to access the tumor was on the midline. And Professor Dr. Florian chose this approach. So this is the skin incision, and these are the bore holes and the size of the bone flap. So the retrosigmoid approach that I've been telling you about is a posterolateral one, and it has close relationships with the transverse sinus and sigmoid sinus, right at their confluence. And if the lesion is bigger and needs more space for the surgeon to access, we can choose a far lateral approach, which is more invasive, implies connecting of the foramen magnum and as well as the first two vertebrae. Transpetrosal approaches are lateral, and I've told you about one here. So these are the lines that delimitate the anterior extent of them. So up to here is retrolabyrinthine, translabyrinthine. Here are located the semicircular canals. Here is the cochlea, and transcochlear ones are the most extended. And here the arrows indicate the root of the approach. And the anterolateral approaches are subtemporal, transtentorial, and Cavase approach, which combines a subtemporal transtentorial approach with anterior petrosectomy, and is called Cavase approach due to this area, which is delimited laterally by the great superficial petrous nerve, medially by the petrous ridge. This is the serine ganglion and the roots of the trigeminal nerve, and it has anterior the mandibular root of the trigeminal nerve, and here is the geniculate ganglion. So here is the geniculate ganglion, great superficial petrous nerve. Here would be the cochlea, but has been drilled, so we can see the internal carotid artery in its petrous segment. You know, the internal carotid artery has a very sinuous trajectory in its cranial part, and maybe we'll dedicate it one.
Yeah, there are 7 segments. Cervical, pietros, lacerum, nu știu, una dintre clasificări. Mai există o clasificare pe care a făcut-o și profesorul Abdurauf anul trecut, care e alta decât cea pe care o știam eu. O să facem când facem vascularizația, mai bine, ca să nu ne complicăm. Dar sunt importante din același motiv, ca și la fosă, cum v-am spus, pentru că practic îți explică pe unde trece carotida și ce are în jur. Ăla e segmentul pietros pentru că e în stânga temporalului.
I wouldn't want to have an incident like an internal cerebral artery hemorrhage in this area.
And the middle meningeal artery. N-ai arătat-o. Uite acolo.
Here, the middle meningeal artery.
Ok.
Of course, Francesca, you can interrupt or add anytime you
I already did.
yeah, and Dan as well. You have more experience than I, so feel free to add information. So, what is actually the retrosigmoid approach? It implies a versatile type of craniotomy, which means it can be tailored to patient's anatomy and we can vary a little bit and create a panoramic view of the posterior fossa from tentorium cerebellar to foramen magnum. So through our retrosigmoid approach, we can see theoretically the whole cerebral confinement. What are the indications for this approach? Resection of extra-axial lesions such as tumoral ones, vanoma, meningioma, epidermoid, cranial nerve neurectomies, vascular decompression of cranial nerves. The most popular is trigeminal nerve vascular decompression. You know that the superior cerebellar artery describes a loop, an inferior loop, which can compress the fifth nerve and lead to trigeminal neuralgia, which is, I'm telling you, it's so severe that, let's say, in patients who have this pathology for like 20 years, to have 20 years this pain, sometimes they commit suicide. It's unbearable. So it's much better to have a Janeta decompression and allow the patient to have a normal life and not commit suicide. It's really bad.
Yes.
We can also alleviate vascular disorder of the vertebral basilar system and approach parenchymal lesion of the brainstem or of the cerebellum. So things we have to bear in mind or steps of this approach.